This video will discuss the variables that impact articulation and phonological development and performance in children. So there are many things that can happen that impact speech development. Anatomical structures within normal variation do not affect speech sound learning. So that might be teeth, missing teeth, or jaw bites. Things that are within the normal aspect of development aren't going to impact speech sound development, but other anatomical structures that are not normal, such as cleft palate will. Significant malocclusions may affect speech sound learning. A malocclusion is where your jaw does not line up, so a significant overbite or underbite. Unrepaired clefts of the palate and velopharyngeal insufficiency may impact speech sound learning. So cleft palate can be obvious. You can see a cleft lip, you can see an opening within the hard palate, but sometimes you can have a submucous cleft, which won't be obvious until further examination with an oral mechanism examination. Velopharyngeal insufficiency, the flap that is supposed to close off the nasal cavity from the pharyngeal cavity from production of most speech sounds, with the exception of the nasals. So sometimes that velopharyngeal flap won't always close appropriately or adequately, so that can make a child sound more hypernasal. Impaired neurophysiological structures and functions may impact speech sound learning, such as cerebral palsy and childhood apraxia of speech. And then somewhat slower didiocokinetic skills, such as speech motor skills, may be associated with speech sound disorders, particularly childhood apraxia of speech. So your anatomic structures include your lips. That includes your size, strength, and mobility, how much you can close your lips, push on the lips. Gross structural abnormalities that prevent contact, approximation, or lip rounding, such as a cleft lip. You can have a cleft upper lip, short, stiff upper lip. So when a child has a cleft lip prior to repair, there might be some compensatory methods you can teach them to produce sounds that are close to the sound production of someone who does not have an impaired cleft lip. You can have abnormalities in teeth, such as missing teeth, malposition, alignment of the dental arches. Your molars are supposed to align, as you can see in this picture here, that this is not alignment. These molars should line up where they fit, basically one on top of the other. You should have a slight over alignment of your top teeth to your bottom teeth. There are class 1 malocclusions, class 2 malocclusions, and class 3 malocclusions. So the class refers to the type and severity of a malocclusion. Is it overbite? Is it underbite? Or is it where actually the teeth are lined up right on top of each other and you have no overarching of the dental palate going on? The top teeth are not coming over the bottom teeth. The cause of or associated with articulation disorder for teeth, typically the only thing we'll see when missing teeth are there are lisps, frontal lisps specifically, but sometimes you can have other issues if the malocclusion is extremely severe. And again, you can teach them compensatory manners to produce sounds. Regarding the tongue development, you have anatomic variation. Ankylosglossia is where your tongue is not large enough or sufficient enough. Surgical alterations such as glossectomy, so the tongue might be cut off due to maybe oral cancer, tongue cancer, and you can again teach compensatory strategies to produce speech sounds. I talked in the previous lecture about tongue tie and that's impact on speech, and the research really doesn't support that it impacts speech sound development, but it can impact swallowing and latching on bottles and nipples. The hard palate, you can have normal variations in width, length, height. A high palatal arch might be hard for children to elevate that tongue to produce some of those back sounds sometimes. So sometimes you might see that they take more time to develop. Sometimes surgical intervention may be needed for clefts or surgical removal. There are prosthetic devices and surgical procedures to repair cleft palates, submucous cleft palates, which would be in the soft palate area more than the hard palate, and also maybe some prosthetic devices such as dental devices that can create a closure within the palate. The soft palate, you need sufficient elevation, range of motion, and symmetry. So again, that velopharyngeal flap needs to close adequately between the pharyngeal cavity and the nasal cavity, and if it doesn't, that creates hypernasality. You need the velopharyngeal closure for production of pressure consonants. So you can teach compensatory articulation that results in substitutions, weak pressure consonants, nasal emission, which is hypernasality. You can have prosthetic devices, and sometimes a surgical procedure is needed. The only way to identify an insufficient velopharyngeal flap closure is through a video fluoroscopy examination. So they would insert a video into the nose and have speech production during that to observe the velopharyngeal flap. So that is something that we would not diagnose that alone as SLPs. We would do that in conjunction with perhaps an ENT or other type of oral doctor. So the peripheral and central nervous system, that's the brain controlling speech production. It's essential for normal and typical acquisition and production of speech. Damage affects the neural control of speech muscles. You can have motor speech disorders such as dysarthria, which is where they cannot produce the sounds. You see this in patients who have had strokes. Sometimes they end up with dysarthria or apraxia. It has reduced intelligibility, includes respiratory, voice, resonance, and prosthetic problems. Apraxia is speech motor programming, and these create articulatory problems. And you can teach compensatory strategies to produce sounds. So apraxia, it's motor programming and planning. Dysarthria is actually being able to physically produce those sounds motorically. It's not the planning, but the physical production of sounds. Apraxia, you're going to see inconsistent speech sound errors. So it might be tat sometimes, it might be cab sometimes, it might be cot sometimes, all for the same word. These are the kids who may have vowel errors, and again, you can see apraxia in adults who've had strokes. So you have general motor skills, so children need to have sufficient motor abilities. Children with cerebral palsy or other neurological damage will not have these skills. You also need to have sufficient oral facial motor skills, including diodocokinetic rate. And so that's when you have the child say pa, ta, ka, but you have them do it as rapidly as possible. Putaka, 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 putaka. The other way you can have a child produce a diodocokinetic rate is to say buttercup. It's the same sounds. Buttercup, 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 buttercup. And you want the child to produce that. It just gives a measure of motor programming and how well a child can move into those three consonant position sounds, because you have the stop sound, the alveolar sound, and the back sound, pa, ta, ka. Deficiencies are neither necessary nor sufficient to produce disorders of articulation, though, so you can still have adequate articulation even with these slower diodocokinetic rates or oral facial motor skills that aren't as strong as their peers. We should not be doing non-speech oral motor exercises, so wagging the tongue back and forth, clicking the tongue over and over to teach speech sounds, because the research does not support that those are going to correct a speech sound disorder. We have variables related to speech sound learning, such as significant hearing loss that negatively affects speech sound learning. Most children who misarticulate can still discriminate speech sounds others produce. Auditory discrimination is not a significant variable. That means that doesn't significantly impact speech sound learning. Oral sensation is not a significant variable unless in adults when the mouth is anesthetized. So if any of you ever had your wisdom teeth out and have had anesthesia for any other type of procedure, you know how sometimes it can be difficult to produce speech sounds. But overall, these things are not going to impact speech sound development. The only thing that really impacts it is hearing loss to a moderate to severe level. So even a mild hearing loss, you should still be able to produce speech sounds adequately. So hearing is essential for acquiring speech and monitoring speech. So if a child is hearing impaired, we want to look at the onset of the hearing impairment, the type, degree, and variety of speech problems. So the age of onset is going to impact speech sound learning. If a child is hearing impaired from birth, they're going to have a delayed speech sound learning without proper amplification. But if a child is 2 or 3 at the onset of hearing loss, then they've already had some time to acquire speech sounds, develop speech sounds, excuse me, and possibly have a speech sound repertoire that can compensate for their other deficits in regards to their hearing loss. So if they lose hearing, it's just going to depend on how much they had before the hearing was lost. The type of hearing loss, so is it a conductive or sensorineural hearing loss? You can have children throughout childhood who have chronic otitis media or ear infections. So that would be a conductive loss at the time of the infection, but that could impact, excuse me, speech sound development as a child isn't hearing sounds in a certain frequency range. The degree of the loss is a mild loss, a moderate loss, a severe loss. Severe and profound losses are the only way speech sound will develop is if they have amplification. And then they can have a variety of speech problems. And also the type of loss can include perhaps maybe auditory neuropathy. So that is whenever a child has varying hearing. So it sounds muffled like the Charlie Brown teacher voice. So it's very unclear. But some days they can hear more than others. The hearing will vary on different days because it's an impact in the neurological pathway. It's not actually in the outer ear or middle ear or inner ear where the loss is occurring. It's along the cranial nerve. In regards to auditory discrimination, auditory discrimination of speech sounds, it's not a strong variable correlated with speech sound disorders. It's the ability to identify correct and incorrect sound production. So you can often have children who have a speech sound disorder but still can distinguish date from gate and correctly identify the two separate words, even though they can't actually produce those words separately or those separate phonemes of the D and G sound. They treat sound production to the effect of auditory discrimination. So you can use auditory discrimination to try to treat the sound disorder, but again, children often can discriminate or hear the difference, but not necessarily produce those sounds differently. Oral sensation, the oral form recognition, it's unclear, and there are contradictory implications on how a child feels food in their mouth, like the sensation of feeling something in their mouth. So it's not necessarily impacting speech sound development. Now, sensory deprivation, so children who have sensory disorders, they have possible effects on articulation, but there's nothing conclusive to support that a sensory deprivation is going to lead to a speech sound disorder. Other variables, language disorders and speech sound disorders may coexist in 35 to 75% of children with speech sound disorders. So that's a very large comorbidity. Comorbidity is when you have two conditions together. So speech sound disorders and language disorders are very strongly correlated. It's highly likely if a child has, especially a severe speech sound disorder, that they also have some language deficits. Genetic research also supports this finding. Speech sound disorders are more common in boys and girls, but that doesn't necessarily mean that you're more likely to have a speech disorder if you're a boy than a girl. It could be with having to how we identify the disorders at the time and age of development. In children with intellectual disabilities, speech sound disorders are more common than in those without children without intellectual disabilities. And then the personalities of children and their parents and socioeconomic variables are not significant variables for speech sound development. So what that means is that maybe you have a child who's more willing to learn or a child who's not very willing to learn, not very motivated. That's not going to impact whether or not they have a speech sound disorder. Same thing for their parents. Their motivation is not going to impact a speech sound disorder. Socioeconomic, there may be a higher incidence of speech sound disorders in children from lower socioeconomic backgrounds, but that doesn't mean that it's actually a causation of speech sound disorder. There are lots of factors there of why children from low socioeconomic status might have a speech sound deficit, or because they also have likely language deficits. There's likely other social emotional issues there with maybe if a child is homeless or a child in poverty when they're not being exposed to vocabulary and language enriched environments as much as their peers who are not from a disadvantaged socioeconomic status. Language skills. Language subsumes articulation. They're happening at the same time. They exist together, so these definitely impact speech sound disorders. So there's a strong relation between articulation and language. Up to 80% of children with phonological disorders may have language problems. Recall from the last chapter that up to 60% of children with phonological disorders have later literacy problems, and literacy, reading, is a language-based skill. Children with severe phonological problems may be more likely to exhibit both a simultaneous or related language disorder and a phonological disorder. Children produce increased errors as syntax and syllable complexity increase. So as the language becomes more complex, maybe it's more multisyllabic words, 4-syllable, 5-syllable, 6-syllable words, then they have more sound errors. As the sentences become longer and more complex with subordinate clauses, then they're going to have more sound errors. So are reading skills associated with articulatory proficiency? We know that children who have poor phonological awareness have been associated with poor reading skills, and there's a whole chapter dedicated to phonological awareness in the book. But basically what that skill is the ability to isolate, identify, and manipulate sounds and words. So it's the ability to recognize how many syllables are in the word. It's a lot of the abilities you had have in your phonetics course to be able to identify the sounds and words. So you have to be able to say all the sounds in cat, k, at, or maybe manipulate the sounds. Say the word cat, now change the k to b, and what's the word? This is an essential pre-reading skill because you have to be able to segment words into their individual sounds in order to be able to decode words or read words on the page, sound them out, and even to spell words. So that's encoding. So how do we spell the word? Genetic factors. A family prevalence of speech sound disorders may be as high as 40%, meaning that if you have a speech sound disorder in your family, there's a 40% chance that your child will also have a speech sound disorder. So up to 40% of relatives, especially brothers, only 20% of sisters may have it. So there's a genetic factor there, but we haven't identified a specific gene. We know chromosome 3, possibly 1, 6, and 15 may contain genes of interest for speech sound disorders, but nothing definitive. And the FOXP2 on chromosome 7 is not especially relevant to speech sound disorders, but it was thought to be a speech gene at some point. So genetic research is really so relatively new in the terms of how long we've been researching genes that we have no definitive answer on specific genes that can cause speech sound disorders. Personal characteristics, age is significant in learning, so a child has to be ready to learn whenever if we want to treat speech sound disorders. Unclear the variables for mastery, meaning how old children are. If you recall looking at your tables in your textbook, there's a variety of what age children learn to acquire sounds, and again, that has to do with how the studies are conducted. So we can't say definitively all children should have the stop sounds by age 3, but it's likely that most children do have those sounds by age 3. There's a neurophysiological maturation and environmental feedback and learning, so you have to have somebody talking to you and listening to you in your environment to be able to learn speech sounds. Gender is not statistically significant, so although there's a higher instance of boys being treated for speech sound disorders than girls, it's not significant enough to say a boy is more likely to have a speech sound disorder than a girl. Articulation disorders are more common in boys, but there could be a variety of factors of why that is. We're more likely to identify boys than girls because of their personalities sometimes or the age of development. So intelligence, the only significant factor here is that there's a high prevalence of articulation disorders in children with intellectual disabilities. Again, nothing for personality. and socioeconomic status, slightly greater number of children with misarticulations, but it's not significant enough to say definitely you'll have an articulation disorder if you're from a low SES background. Articulation has no significant association with birth order and number of siblings, so a firstborn versus a thirdborn. Language development is associated with birth order, so the later you are in your birth order, the later your language will develop. Familial prevalence may be higher in some families, but not all. Again, about 40%. Siblings of children who misarticulate and children of parents with a history of misarticulations may perform poorly on an articulation test. My brother had a speech sound disorder until about 12 years old, and he has 2 sons, and one of his sons does have the same speech sound disorder. He also has sound errors that are impacted by his jaw positioning with an underbite. So there might be things that won't be able to be corrected until his jaw positioning can be corrected. Tongue thrust, that is a frontal lisp pushing forward, is also known as a reverse swallow or infantile swallow. So a good test for yourself if you're wondering if you tongue thrust is to take a sip of water or some type of drink and smile with your lips open and show your teeth, and then swallow. And if a child is tongue thrusting or an adult is tongue thrusting, then when they push that tongue forward, the water is going to come out, versus if you swallow normally, which is push up and back with the tongue when you swallow, then the water won't come out. So it's a forward tongue gesture during swallow and forward carriage of the tongue in the mouth, possible fronting of the tongue during speech. So the potential speech problems are a lisp and distorted productions of the z and l sound. Or you can also have interdentalization of the alveolar sounds of t, d, n, and l, meaning that the tongue might come and touch the teeth or between the teeth for the sound production. So it's fronting of the tongue. It's a functional habit or organic condition. So sometimes children's mouth, the tongue doesn't necessarily fit in the mouth as well as it should. Maybe a large tongue, and so you might have open mouth posture. The tongue just sits there. The mouth sits open habitually. So it may affect individual placement of teeth. You can have teeth that jut out or protrude, and again, it may be associated with the lisp. This is usually a mild treatment, so you give exercises and practice and just have to reteach the person who's doing this how to swallow appropriately. There's a lot of self-monitoring involved with this. So studies have shown correlation between variables studied and speech sound disorders, but there is no definitive cause of speech sound disorders. These things are correlated, they're related to each other, but they're not causing, one's not causing another. A positive correlation may only mean that some other unspecified variable is causally related to speech sound disorders. We don't have a definitive conclusion of what causes it. Genetic research has not established a genetic cause, and treatment of speech sound disorders remain behavioral, meaning that we're teaching children how to say the sound correctly. Even if specific genes are isolated, we're still going to do a behavioral training, and when we get into articulation therapy and how we do that, it's basically conditioning and saying, okay, this is how you say the sound, and the reinforcement of, yes, that's correct, that's how you say the sound, and the social reinforcement from that.